या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Hello, dear doctors. Very good evening to one and all, and thanks for joining on this Saturday evening. This is Dr. Roshali from the medical team of USV. A very warm welcome to all the speakers and delegates for this unique initiative that is a launch of CME India Group. What is CME India? It is India's most premium academic group of internal medicine since 2016. This group is brought in collaboration with USV for the excellence in academics to the physicians. It is an initiative by a very dear Dr. N.K. Singh sir, and it's a platform created to add specialized domains of all the branches of medicines. It aims to impart 24-hour knowledge about patient care, get daily access to live case discussions, interspecialty discussions on just a click, thus sharing medical education with fun and vigor and ultimately improving healthcare for millions of people. With this brief, I would like to welcome the lead person behind this great initiative, Dr. N.K. Singh sir, and the respected chairperson for today's evening, Dr. Bijay Patni and Dr. Akash Singh sir. Can I have the slides, please? Dr. Bijay Patni sir is working as an HOD at the Diabetes Wellness Clinic, Kolkata. He is a founder of Diabetes Research and Welfare Association. He is a speaker and faculty at various conferences. He has been awarded multiple fellowships. He has participated in various studies and clinical trials also, and have contributed a number of articles and chapters. He is also a life member of various professional bodies. I welcome you, sir, on behalf of CME India and Team USV. Our second chairperson for today is Dr. Akash Singh, sir. He is the president of Indian Diabetes and Cardiometabolic Diseases Association. He is also the vice president and executive body member of multiple professional bodies. He has published numerous research papers and textbook chapters. He has given several talks at the national, regional, and state level conferences. He has been very active in research and a PI in multiple investigations. I welcome you, sir, on behalf of CME India and Team USV. And finally, a lead person for today, Dr. N.K. Singh, sir. He is the director at Diabetes and Heart Research Center, Dhanbad. He is the admin and founder of CME India WhatsApp group, and editor of www.cmeindia.in and www.diabetesdhrc.com as well. He is a member of various professional bodies. He has edited Millennium Book of Medicine. He is also an associate editor for the Postgraduate Medicine 2021, edited monograph on COVID by ICP and API 2023. And he's also a fellow from WHO. It's great to have you here with us today. I welcome you, sir, on behalf of CME India and Team USV. Also, in this program, we are going to have live poll questions where we will require all the expert opinions. With this, I would like to hand over the session to Dr. N.K. Singh, sir. Over to you, Dr. N.K. Singh, sir.
Thank you, Doctor. Thank you all, and welcome to all our today's guest, Dr. A.K. Das. I think India will never have such a brilliant mind which has initiated so many ideas, and one of the great leader of this time, Dr. Banshi Saboo, the future leader, I always say, in India. So I think with this, and I have got two pillars of this CME India, one Dr. Bijay Patni and Dr. Akash Singh. Without him, I think, without help of both, I think the further initiative might have not been successful. So how it all happened that USV is here, I will just explain in 5 minutes, and then we will go for the academics. This CME India group or CME India has evolved into a dynamic platform today with a wide-reaching impact since March 2016. So you can see we have started this in the 2016, and it was the March 23, and since then it has undergone a significant growth and development. So initially, it was started with one group of 255 persons. The idea was that there should not be any social messages. We will discuss cases, updates, and live discussions. And then we have some MD from all the parts of the India. Then we also added many super specialty persons so that we can get the best of the comments and that then can lead to our day-to-day practice. So this was a very important problem that time. In the 2016, if you remember, the social media has every day the good morning and birthday post, and this guy has a great time of a struggle for removing all those notions that this could be also a scientific platform. And I'm really very much thankful to Dr. Banshi and Dr. Manoj that at the Diabetes India, they gave me to discuss how this WhatsApp CME can change the whole perspective of the medical education. So we had enforced the rules, prohibiting the post related to greetings, birthdays, everything. And then we started all these things discussions. So we had slowly at that time, the WhatsApp capacity was limited to 255. Then you are well aware, today it is around 1024. So members have till date, although the data says that more than 15,000 live cases has been discussed in this forum, many updates have been shared. And during the COVID time, it was like pranavayu. So many inputs, whenever I go to any part of India, even some non-medical persons from the pharma people or some corporate houses, they come and say that your WhatsApp group has helped us too much during the COVID times. And you will not, basically when we released I edited this COVID guideline, that time, within 1 week, it was 4.5 lakhs hit worldwide. So that gave from the page number 3 from the Google ranking to top most position on the Google. So from that time, then we started during the COVID time, then our team members, our experts, our members said that there should be a website for this. So we started a CME India website, and today you will be happy to know that our case study section has become so popular that even I had got mails from the Yale University and BMJ, and they are trying that we should be some tie-up with those BMJ group and that. So this is a great thing, I think, but we have not decided what to do now. In the meantime, I think 3 months back, Dr. Akash and Dr. Patni, we had some meeting and meeting with some USV top persons. And because that my capacity of adding members was limited, so I think we even after starting 4 groups, we had something around 35 to 4,000 members. But you will be, I am really surprised that USV started the group. They came that they will not interfere anything in the group, but just they will add the members and they will support me for adding members and for the CME of the doctors from the pan-Indian side. So then I think today they had 3 groups, USB, USB 1 and 2. Each group is full. Something around 3,000 persons have joined. I am really surprised that even the USB groups are so active and lots of cases are being shared and being discussed. And we are looking further to start more 3 groups in days to come. So I think this is how we have started. We have also, with the help of Dr. Akash and Dr. Patni, we have conducted one study on the CME impact of the WhatsApp. And I think this is under process and we will be able to publish that also. So bringing together the physicians, the super people or super specialists across the country, we had fostered interactive discussions and many things. And now this new thing in the India, that most of people followed it and they have started discussing the cases and other things. With this, I think that Ashok Kumar Das, I have the
Yes.
greatest respect for you, sir. And whenever I meet him, I think he's a great inspiration to me. Apart from Dr. Banshi is my mentor, I say, but Dr. A.K. Das every time gave me so much support mentally that I am really happy, sir, that today you are here. Dr. Banshi is here, and Dr. Akash and Dr. Patni is the part of the group. So I think with this, I will end here, and I will
Yes.
start. I will just share the screen with the
Yes,
Dr. I
thank
think Dr. Patni and Dr. Akash Singh, please come forward and start the proceedings today. Thank you, sir. Thank you very much.
Yeah, thank you so much, Dr. N.K. Singh, sir, for enlightening us throughout the journey of CME India. Now, I would request Dr. Bijay Patni, sir, to kindly introduce Dr. A.K. Das, sir. Over to you, Dr. Bijay Patni, sir.
Thank you, Doctor.
Can we please have the slides? Yes. Can you please have the slides?
Thank you.
Over to you, sir.
Thank you. Good evening, and thank you, Doctor, for introducing me, and thank you, USV, as well. It's a great evening for me today because we have two stalwarts today joining us, and one of them is the most inspiring leader I have met, Professor A.K. Das, and I do remember his encouraging words as and when I meet him, and that obviously propelled me forward to take some initiative someplace. And we all are aware of Professor Das. He has been at the helm of affairs of almost all the organization in India, and he has been the head endocrinology at JIPMER Pondicherry. He doesn't need any introduction, basically. And then we have the global India leader of diabetology, I would say, Professor or Dr. Banshi Saboo. I think he probably doesn't need introduction internationally. And I am very thankful to him to know that Diabetes India session will be there in ESD, and this initiative will propel us all to the next pedestal, I would say. So thank you, sir, for joining in, and we will start the CME part. And I request Professor Das to speak on the pharmacological management of prediabetes. It's all yours, sir.
Thank you, my dear Dr. N.K. Singh, my dear Professor Bijay Patni, my dear Akash Singh, and the entire, and of course, Banshi Bhai, and the entire team from the USV and the entire audience who have joined us today for this great webinar, which is a game-changing webinar, which can change the destiny of the country. I'll tell you why I'm saying so. Can I have my slides first, please? Slides, please.
Yes. Yes. Team, can you please share the slides?
Dear friends, I must tell you, we no more talk of prediabetes as a disease. We say prediabetes is the latent diabetes. Because if you say, or we call it early diabetes. Now, can you make it full screen? Dear friends, good. So I am going to talk about the pharmacological management. Can I have the next slide? Dear friends, I have got this presentation, 6 aspects to talk to you. One is pre-diagnosis of diabetes, why it is important. Number 2, increased risk for becoming diabetic and increased risk of developing cardiovascular disease that occurs in pre-diabetes is much more than diabetics per se. Number 3, early manifestations of pre-diabetes represents as impaired fasting glucose or impaired glucose tolerance. And you know, by the time pre-diabetes sets in, at least there are various literature talking about even 67, 68%, but at least 50% beta cells are lost while we diagnose pre-diabetes. That's the importance of pre-diabetes. It is already early diabetes. It is associated with obesity, which is a world malady today. And this obesity can be abdominal or can be visceral. And dyslipidemia with high triglyceride, what we call triglyceridemic waste or metabolic syndrome, and low HDL cholesterol, and with hypertension. Interventions can reduce the role of progression, the rate of progression from pre-diabetes. That is the most important part of my talk today. that it can change the destiny of the world. Next slide shows about the prevalence. Can I have the next slide? It shows this is our paper which published on the 7th of June. It's exactly 2 months back in Lancet. This is the biggest study India has done about the ICMR in-depth study. And I want to point one thing. See, if the diabetics today is about 1.2 million, the pre-diabetes is 136 million. Therefore, dear friends, I want to highlight that pre-diabetes is a bigger problem than diabetes. That is the reason why we should be very, very careful about the pre-diabetes. Next is a heat map. Can I have the heat map next one of the pre-diabetes in our country? You can see the prevalence, the overall and the area-wise weighted prevalence of pre-diabetes. To make a long story short, I must tell you, the prevalence is as much as 37% in Sikkim, about 28% in Tripura, about 26% in Kerala, and is about 20% in Pondicherry. So I would like to describe that pre-diabetes is a very important malady for our country. And this is the highest in the central and the northern region of the country, the lowest in Punjab, Jharkhand, and some parts of the northeastern region, where the physical activity is great. And the prevalence of pre-diabetes was not significantly different between urban and rural areas. I'll dilate upon it. The prevalence of diabetes was about 11.4% in our country. But this 11.4% a differential between the urban and the rural. It was about 10.9 in urban areas and less than 9% in the rural areas. But this division of urban-rural dichotomy is not found in the pre-diabetes. Therefore, the rural populations are as much likely to become pre-diabetic as the urban population. Therefore, it calls for urgent action. The protection rural people have from the diabetes is not there in the pre-diabetes, and they're waiting to become full-blown diabetic. Next slide. Dear friend, now this, I must tell you that the Asian phenotype is comprising of higher waist, highest level of total and visceral fat, hyperinsulinemia, and greater susceptibility to diabetes, and insulin resistance is the perfect recipe which hastens the progression of pre-diabetes to diabetes. Next slide describes it all. Can I have the next slide? Now, the conversion of pre-diabetes to diabetes has been studied by many. I have brought two studies. One study, the CURE study and the DCLIP study. I must tell you that among those with normal glucose tolerance, 19.4%, that is 20%, converted to full-blown diabetes, and from normal glucose tolerance, 25.7% to pre-diabetes, giving an overall conversion to dysglycemia about 45.1%. Among those with pre-diabetes, 60% converted to diabetes. See the burden of the disease. One of the highest global rate of pre-diabetes progressive type 2 diabetes is in our country. Next slide. Dear friends, I must tell you that insulin resistance, a strong predictor of pre-diabetes, goes hand in hand with visceral obesity, hypertension, glucose intolerance, dyslipidemia, endothelial dysfunction, end organ damage, and hyperinsulinemia. Therefore, this is the most important part to consider. The pre-diabetes cannot be taken in isolation and a great malady. Next slide. Dear friends, therefore, today we will prefer to use the term early diabetes. The pre-diabetes gives a sense of false protection. So we have now trying to popularize in the diabetes management centers should be around the theme of not pre-diabetes, but early diabetes. And we have devised, me and Banshi, many of encasing a full compendium of what is early action against diabetes. And this early action against pre-diabetes is the order of the day. I'm coming toward the end of my presentation. Next slide. I'll just highlight that the diagnostic criteria is approved by the ADA, WHO, IDF, IGT between 140 to 199, with the fasting glucose is normal. IFG, when the IGT is normal, the prandial glucose is normal, but fasting between 100 to 125, or by WHO 110 to 125. HbA1c between 5.7 to 6.4 is the diagnostic criteria for the pre-diabetes. Next. Dear friends, I must tell the most important. What are the goals of pre-diabetes management? To prevent pre-diabetes, to become diabetic, lowering the microvascular risk, promoting pre-diabetes to come back to normoglycemia. And cardiovascular risk factors in the pre-diabetic must be managed, like smoking cessation, hypertension management, and reducing the serum lipid levels. Next slide, please. Dear friends, the most important way to prevent pre-diabetes, to go to diabetes, are definitely lifestyle, like diet, exercise. When these two fail or are not possible, I'll again mention, when these two fail and not able to work properly, we resort to pharmacological therapy. We do not want to medicalize this condition. But in majority of pre-diabetes, there's a need for pharmacological therapy. And today, I just start this discussion, then the Banshi will take over. Next slide. Dear friends, the pharmacological therapy, the threshold of action of the pharmacological therapy is based upon the severity of hyperglycemia and the self-perceived severity, and poor adherence to nutrition and poor response to life cycle therapy. So the treatment of pharmacological agents are indicated when the hyperglycemia is severe within the range of pre-diabetes. We perceive that the pre-diabetes is severe and poor adherence and poor response to lifestyle measures. Next slide. Dear friends, amongst I'll just give a poll question. In your clinical practice, in scenario, which of the following is situation prompts you to initiate a preventive metformin therapy? Obesity, age younger than 60 years, both impaired fasting glucose and impaired glucose tolerance, risk factor of H1C when it's more than 6%, hypertension, low HDL cholesterol, and elevated triglyceridemia, and family history of diabetes in a first relatives. So I've given you a case scenario. So let us see in our clinical scenario, which of the following situation prompts us to prescribe metformin therapy. Can I have the poll result, Dr. Aishwarya?
Yes, sir. Yes, sir. Dear delegates, I kindly request you to participate, and team, can you please launch the poll results as we get the optimum amount of opinions.
Okay, I think the answers are coming on. You can see from 16% to 43% to 14% to 29%. The answer I can give to this, all the 8 scenarios given here are the scenarios where the metformin therapy can be started. All the eight. I'll come to it in a minute. Next slide. Next slide, please. So obesity, can go back. It is becoming can I go back to previous slide? So obesity, can I go back to previous slide, please? Previous slide. When there's a diabetes, pre-diabetes below 60 years of age, when both IFG and IGT are present and high, the H1C is 6%. That is, normally it's 5.7, is 6% or above. Hypertension, there is hyperlipidemia, low HDL with high triglyceride, and a strong family history of diabetes in a first relative, one must start metformin. Next slide. Next slide, please. Now, the role of metformin is 3. Number 1, primary prevention of diabetes when metformin is given from the perspective of diabetes prevention. Number 2, secondary prevention of diabetes when metformin is given in the pre-diabetes patients. Third, primordial prevention of vascular ill health, like when metformin is given to all pre-diabetes patients to prevent vascular complications. So this role of metformin are 3: primary prevention, secondary prevention, and also primordial prevention. Next slide. Now, there's a long-term safety and tolerability and weight loss associated with metformin, the diabetes preventive program. I will not go to all the programs. We have a DPP program from the USA. We have the DPP program from the Northeast countries. We have our own Indian. Can I go back next slide? Where we have given the own Indian IDPP program, where we have used the DCLIF study and other studies. And the amount of metformin used in the studies done abroad is about 850 twice a day. But the study that we have done in India by Dr. Ramchandran et al., I must tell you, it was supported by USV, is the dose required was about 500 milligram daily, and sometimes they use 500 milligram twice a day. Therefore, the dose of metformin happens to be less in the Indian population. Next slide. Next slide. Now, during the 3-year follow-up period, there was a 32% risk reduction in the people who took metformin compared to the control subjects. So it was less, at least by 32%. And most participants, that means where the lifestyle failed or those who were not able to do lifestyle, was about 72%. So that is my message, that majority of the pre-diabetics need metformin, and you can give almost 32% reduction in the conversion rate to diabetes. Next slide. Next slide. Now, so the Indian scenario, I was referring to this paper, Indian Diabetes Prevention Program showed that lifestyle modification of metformin to prevent type 2 diabetes in Asian subjects with impaired glucose tolerance. You can do it with lifestyle, but it is probably easier to do it metformin and more practical. Next slide. There is the surprising revelations of the Indian Diabetes Prevention Program that metformin was effective to reduce progression to IGT to full-blown diabetes, a much smaller dose, that is 500 milligram per day. I told you a minute back, compared to DPP, where 1700 milligram per day, 850 BD was used. Low number of people needed to be treated with metformin to prevent one case of diabetes, that is 6.9. So NNT, number needed was 6.9, contradistinction to 13.9 in the DPP. So IDPP showed that metformin used to lower doses was equally effective in the lifestyle management to prevent diabetes in Asian Indians through high risk. Dear friends, so what do the guidelines say? I'll end with this next line. Due to any guideline, next slide, please. The ADA guideline says that pharmacological intervention with metformin is important. ICMR guideline says sufficient evidence that metformin intervention can prevent type 2 diabetes onset in pre-diabetics. Next one. I must mention you with pride that the RSDA guideline, our own guideline, recommended the use of metformin in the management of type 2 diabetes in 2022 edition of the RSDA guideline. Next slide. And you know that various guidelines, Latin American guideline, Canadian guideline, IDF guideline, Malaysian guideline, all say that the metformin must be used to prevent pre-diabetes going to full-blown diabetes. Next one. Next slide. Dear friends, next slide, the last slide. Depending on this, the DCGI has approved metformin to be used for use in pre-diabetes. So metformin became the first oral treatment to be approved by DCGI in India for use in the pre-diabetics. I'll just read the recommendation before I end. The approved medication of the use of metformin SR in pre-diabetes as follows: reduction in the risk of reduction in the risk or delay in the onset of type 2 diabetes in adults, overweight patients with IGT and IFG, and those who have increased H1C, and those high risk for developing over type 2 diabetes, or can still progress to type 2 diabetes mellitus despite implementation of the intensive lifestyle therapy. Dear friends, I will end here because I was given only 14 minutes and I have just finished my time now. Now back to Dr. Australia to call the next speaker, and I'll be here to answer the questions.
Yes. So,
thank you very much.
Thank you so much, Dr. Ekedas. I would request now Dr. Akash Singh sir to kindly introduce Dr. Banshi Saboo sir for his presentation.
Thank you very much. Dr. Banshi Saboo doesn't need much of an introduction. I can recall my classmates who are based in Ahmedabad, Dr. Anupama and Dr. Parindra Desai, who's interacted with Dr. Banshi Bhai in the early days of his career as MD. And both of them, he told that I will do something different, I will do something out of the box, and I will sort of go way ahead rather than doing a routine MD practice. And he has shown this in true spirit. And he has gone from pillar to pillar and is now heading majority of the diabetes and endocrine associations in India and abroad. And he is the pride of India because in organizations abroad, he is now holding various important positions. And this is the list of his credentials basically, which will take a while to read, but I don't think I need to read all of them because it's like showing light to the sun. He is one of the most prolific researchers, most prolific speakers, and most prolific publishers in the field of diabetes and endocrinology. With these words, I welcome him to deliver his talk in the present CME. Dr. Banshi Saboo, sir.
Thank you, Dr. Akash Singh, sir.
First of all, it's really great pleasure to be here, and thanks, Dr. Akash, for kind words. Thank you, Dr. N.K. Singh and Dr. Bijay Patni also. NK, it's really a proud moment that now CME had grown up across the country, and rather one of the biggest online community in the world of physicians, where we have many thousands of the doctors who have already joined it, and with the support of industry now many more Indians, and probably it will become one of the biggest in Southeast Asia and other parts of the world also. I think now this is the time that we should move internationally, as CME India has already grown up in India, and too many physicians are actively participating in our CME activities. Again, a great moment because I am sharing this podium with Dr. Ashok Kumar Das, who is teacher, mentor for many of us, and he's a great man. We all know him and we all have a great respect for him. With the topic which is given to me, and I think it's very, very important that this topic which we have discussed during our COVID days, and actually, let me share my slide first. So the topic is very interesting, as I was reading a diabetes care in 2020, the article after the COVID, and the article was talking about the glucose should be considered as a fifth vital sign, as in hospital management. When patient comes to the hospital, we normally check all the vital sign, which we all know, 4 vital sign. During COVID time, it is, other than the respiratory rate, it is the oxygen saturation, which is very, very important, and one of the most important vital sign when person is getting admitted or even on an outdoor patient department. At the same time, the in-hospital management of a persons with COVID, they found that glucose is also very, very important, and that should be checked also very right at the time of admission. Even somebody may not be the diabetes. On that note, I talked with Dr. Anup Mishra, and then he told me that, okay, we will also write a article, and that I will be discussing here in this. And then after our article, rather, the ICMR had come out with a guideline in the COVID time only that those patients who are getting hospitalized, whether they are diabetes or non-diabetes, their sugar should be checked immediately at the time of admission itself. With the glucose meter, and if they found to have dysglycemia, send their A1C and get their sugar on more regular basis, and to get a good control of sugar, which is essential during COVID time. We all know about the vital signs, and these are the 4 important vital signs. As I already told you now, with the respiratory rate, we started understanding the importance of oxygen saturation, which had become very, very important. But we all physicians, we all clinicians, whether it's a primary care physician or somebody is practicing subspecialty or super specialty, these are the 4 clinically important vital signs we all measure for all our patients. Now, this is one very important expert opinion which I would like to have. I'm sure all of you regularly check in your regular clinical practice. So I'm putting that all of them and all the above are right answer. But here with the respiratory rate, in COVID time, we also started measuring, other than respiratory rate, it is the oxygen saturation. The definition of vital sign is a clinical measurement that indicates the state of body's essential function. And that if vital sign is deranged, then, a clinician has to suspect that there could be something which is not in the right condition for the patient. And that's the reason he has to take care of that patient in a very serious note. With maintaining metabolic and glucose profile is a part of that essential function. And that's the reason we can consider that glucose is also very important vital sign. The only comment which had come when we have written the paper, and that it's not non-invasive, because you have to do something while other vital signs which are very, very non-invasive, and they can be considered vital sign, because even a normal person or even layman can also do those vital signs, while the glucose monitoring requires some sort of an invasive method. But as the number of persons with diabetes and with dysglycemia, as sir was talking about the pre-diabetes, we have so many high in our country, so probably it can be also considered as a fifth vital sign also. Blood glucose level is to be considered as a new vital sign, but why? That's an important question, and that we will be discussing in next 10 minutes. But before that, do you consider checking blood glucose in all your patients? Now, this is a question to primary care physician. This is not the question for the diabetologist or even physicians, because we might be seeing the patients who are more or less you have a diabetes or a with non-communicable disease or with other metabolic problem. So they definitely check the blood glucose level. But what about the primary care physician? We have done long back a study in some of the general practitioner clinic, that a person who is coming to a GP not for the purpose of diabetes, he is coming for diarrhea, he is coming for some coughing, he may be coming for some common symptoms, and by doing the glucose level in that particular patients, we found that 1/3 of them are detected during this in primary care physician clinic, who is a general practitioner, and just checking the patients who are not coming for the purpose of glucose control. They have come for some other complaints, and they found to have 1/3 of them coming to this clinic found to have dysglycemia. I'm not talking of diabetes, I'm talking of dysglycemia. This is very important slide, which already sir had talked about the diabetes and pre-diabetic status of our country. One of the biggest epidemiological study happened in the world on ICMR in diabetes study. Thanks to Dr. Mohan and team, that I was the principal investigator of Gujarat. Sir was also the part of this and the national level, and I was principal investigator of Gujarat. Luckily, we have medium range of diabetes also around 7.5 to 9.9, and similar way we have pre-diabetic status also in Gujarat. But some of the states are found to have higher prevalence of diabetes, and some of the states are found to have more of a pre-diabetes. At present, we have around 101 million people with diabetes and 126 with the pre-diabetes. And then you can understand that how many of them will be having dysglycemia. So that's the reason that there should be any person who is coming to any clinic, anywhere, whenever there is an opportunity for a doctor or a healthcare professional, they must check the glucose value of the person, because that's very, very important, because half of them who are having diabetes, they are not detected. Forget about the pre-diabetic population or the persons with dysglycemia. So it is very, very important that if someone comes in the clinic or anywhere, wherever a healthcare professional is measuring other vital sign, they must check the glucose also, because it's considered a very important vital sign. But even though the number of persons with not knowing about the sugar level, that's also very important. We have done during my presidency in RSSDA, we have done a national campaign. In a one day, we have done 1 million testing, more than one. It was 1.2 million people were sugar were checked. And you will be surprised that even below the age of 30, who were not knowing about the diabetes, 26,000 young people were first time diagnosed in that campaign program in one day. That's one of the biggest number that we have published that paper in American Diabetic Association in the abstract, then full paper. And after that, we have written to ICMR that, at present ICMR is advising the people in India who should be above the age of 30 should go for regular screening. Similar, American Diabetic Association is advising people to get screened for above the age of 35. But in India, we have shown the paper that below the 30, how many people are getting first time diagnosed. And in that paper also, in a sub-analysis, found to have even below the 25 years, there were 6,000 people were first time detected who were not having any symptom. So on that, again, one paper written in Diabetes and Metabolic Syndrome. And on that paper, we have written to ICMR that in India, the screening, instead of doing after 30, rather it should be between 25 to 30 or more than age of 25. All the adults rather should be screened for annually for sugar level also. And that also gives a strength to our paper of that glucose should be considered as a fifth vital sign for all adults who are coming to primary care physician or any healthcare professional for anything. As blood glucose affecting nearly all the body system, as from top to bottom, we always say that hair to nail, a person can be affected by glucose level. High glucose level leads to microvascular complication, macrovascular complication, even periodontal disease, and the foot problem is a major challenge. Neuropathy is a very challenging problem for many of our patients. So from diabetes experts across the nation, this was the one recommended which we had put this in a paper. Need for blood glucose is a fifth vital sign with a diabetes situation is so high in our country, higher in rapid conversion from pre-diabetes to diabetic population, and the studies had indicated that a unhealthy blood glucose level during hospital, the outcome for these persons is very bad. So do you suggest or have a lab attached or a glucose meter to implement fifth vital checking of blood glucose level? Most of the people, and that's recommendation that they should have a glucose meter in a primary care setup also, to check their blood sugar level. Or whenever you are sending the blood sample to the lab, they should simultaneously ask for a glucose level also. That is what is required. This is the paper which I was talking of, which has published in Diabetes and Metabolic Syndrome in 2021. A blood glucose level should be considered as a new vital sign indicative of prognosis during hospitalization, and that's very, very important during COVID time. And health risk associated with blood glucose level, even those who have mild hyperglycemia or mildly upper level, even they may not have diabetes, and that's what they had talked about, the 28-day mortality risk in COVID-19 patients whose fasting blood glucose was more than 126. Lowest mortality risk was found in the range of when the patient's sugar was level between 110 to 140. Highest mortality was patients who had less than 55 or more than 200. So both the extremes, I mean hypo as well as in hyperglycemia, increased all-cause mortality in patients when status is shifted from normal fasting glucose to impaired fasting glucose, increased risk of stroke and all-cause mortality in patient when status is shifted from again normal fasting to dysglycemia. There is an increased risk of CVD in individuals. We all know that patients with higher the glucose level, increased risk of all-cause mortality was there, increased mortality risk in quartile, increase in hospital and 60-day mortality observed in third tertile with admission blood glucose level are between 136 to 162. Each 18 milligram deciliter rise in blood glucose was associated with 31% increase in hospital mortality risk and 12% in 60-day mortality also. Health risks associated with blood glucose level when it has gone in hypoglycemia range, even those who are not having diabetes. So the patients who are increased in hospitality mortality was found in persons with blood glucose level of less than 55. Increased mortality risk is associated with blood glucose level when it has gone less than 40. Even it was also critically ill patients, the mortality was higher. Those patients' sugar was less than 81. So hypoglycemia also increases the mortality in persons with hypoglycemia. This was the paper which was been published in Diabetes Care in 2020. A glucose is the fifth vital sign, a randomized controlled trial of a continuous glucose monitoring in a non-ICU hospital setting. And this they had talked about, a continuously streaming glucose reading may truly be the fifth vital sign, the way we are monitoring them, blood pressure, the pulse rate, the oxygen saturation, respiratory rate, or a temperature. Similarly, they should be continuously monitored for that. To summarize my talk, blood glucose is a requisite for the body to maintain normal metabolic process. Any deviation from the normal range of blood glucose may have adverse consequences and contributes to morbidity and mortality. Blood glucose is one of the important parameters for prognosis in any disease and making it as an essential part of clinical monitoring. To conclude, since now we all consider blood glucose as a vital for all our patients, and I think this we should continue to teach our primary care physicians and other healthcare professionals whenever they get an opportunity, they must check their patient's blood glucose also as a part of regular monitoring, as and whenever they are checking the other vital signs for their patient. Thank you. Thank you very much once again, NK, Dr. Bijay and Dr. Akash, as well as USV team for giving me opportunity.
Thank you so much, Dr. Banshi Saboo, sir.
Can I just say one thing?
Yes, sir, sure, please.
Has important thing. Most important thing is the publication. The sugar must be tested in everybody. Sugar as the fifth vitamin next to pulse, be temperature restoration. And this finding of Banshi and the team has made revolution in India. I personally feel that if this is practiced, we'll find much more pre-diabetics and we can treat them. And as I said, we can change their destiny, our country's destiny. Thank you.
Very true, sir. Very true.
Thank you. Thank you, Dr. Das, sir. Now I would request Dr. Bijay Patni, sir, and Dr. Akash Singh, sir, to kindly take forward to the panel discussion, please, along with Dr. N.K. Singh, sir. So we are having few questions with us from the audience. It's placed in the chat box.
Right. So first and foremost, thank you, Dr. Banshi Saboo, sir, and Dr. Professor Ashok Kumar Das, sir, for the great talks which you have delivered. There are a few questions which are going to take us from the chat box. And the question goes to Professor Das, that how long metformin should be continued in pre-diabetics?
Yeah, that's a very, very important question. To make a long story short, I must tell you, it must be continued for a very long time. How do you devise very, very long time? In the Indian Diabetes Prevention Program, it was continued for 5 years and sometimes beyond. Sometimes if you stop the metformin, they do not go back to pre-diabetes again. Therefore, I personally feel that one must continue this drug at least for 5 years. And after that, periodic checkup is necessary. Because, you know, there's a very heterogeneous population. Some may need, some may not need. But majority in 5 years will definitely convert and may not need for the rest of their life.
Thank you, sir. And the question actually for Dr. Saboo is extremely important, that we did consider vital sign, the fifth glucose as a fifth vital sign. But don't you think that glycemic variability, even in institutionalized patient, could be responsible for increased mortality, and where probably CGM could be an important tool?
So I agree with that. Glycemic variability is also one of the important factors, particularly with the persons with diabetes. The continuous glucose monitoring at this point of time is not advocated, particularly in the patients who are in ICU setting, but those who are in non-ICU in hospital, but non-ICU, they can be given a continuous glucose monitoring to check their glycemic variability. Many papers have been published on this aspect also. I agree with that. That could be also one of the important reasons for their increasing mortality, particularly patients who are in ICU. And that's the reason for an intensive monitoring and intensive control of a glucose during ICU hospitalization, it is required. In hospital management of a diabetes by critical care physician, by ICU physicians, as well as by the physicians who are admitting the patients is really poor in our country, to be very frank. Even we have our own guideline in hospital management, guideline is very much in place. People still go with a 4-hourly or 6-hourly sugar, and then they find that there is a roller coaster in their glucose level. If you check the sugar on a more intensive monitoring method, which is like 1-hourly or 2-hourly, and then accordingly you give them very short-acting insulin or IV infusion, probably the sugar will be better controlled and this glycemic variability can be significantly reduced.
Yeah. Can I just join in, Banshi bhai and
Yes,
Bijay Patni and Akash? I just tell you, esteemed chairpersons, I went to a meeting to Denmark recently. The only thing I learned from there, the lesser the sugar, the longer we live. I'm again reiterating this. You can cross-check. This is a meeting on the animal diabetes, and the message is the lesser the sugar. That doesn't mean you're hypoglycemic all the time. It only says that you have to maintain a low sugar level to live longer. The second point, as Banshi bhai has said, we know that the glycemic variability is worse than having a high glucose level for a long time. But dear friends, in day-to-day life, I'm reading more practical point. To have high sugar is definitely worse. Whether you have a roller coaster or not, that everybody does.
So your audio is yeah.
I think, sir, connectivity is slightly poor.
Yeah. I think your audio is an issue, sir.
Keep your video off, sir. So that probably
No,
the
am I audio?
keep your video off,
So
sir.
is
So
audio
the
better
audio will
now?
be better at least.
Yeah, is the audio better now?
Yes, it is better,
Am I
but keep
audible
the
now?
video off.
So what I'll just finish it quickly to say that to keep sugar low, one can take care of the glycemic variability, but it's not a must to have CGM. The new
Very-
drugs that we have, they take care of the glycemic variability. So having a low sugar is much better than having a higher sugar in spite of variability. Thank you.
Sir, all vital signs except the temperature, keeping them low. The lower the pulse rate, lower the blood
Yeah,
pressure, lower
exactly.
the respiratory rate, all are better
Yeah, yeah,
and give the longevity in the life, except the
yeah,
temperature.
yeah,
The temperature should be
yeah,
the same.
absolutely. In fact, your second paper in the diabetes scan must be this paper. Low, I will give you all the documents that I have with me. Lower
Yes,
the
sir.
sugar, longer the life.
Very true.
Thank you, sir. Taking a few questions forward, I think what Dr. Surendra Gupta has commented, and I would ask Professor Das to comment on that. What are the counseling approaches which you will apply in order, because the prevalence of
Yeah.
pre-diabetes is very high, even the conversion is very high or very rapid. So what are the counseling approaches will be practical for these group of patients which are in pre-diabetic stage?
I think this is a loaded question. I believe three things. I'll be very brief. The advice must go from the healthcare providers at the highest level. I mean treating physicians and the treating sisters, the nursing staff are the best to give the advice, along with the health educators and diabetes educators. Second point, what approach? My approach today, after many years, is like this. One American president died, Eisenhower died. While he was taking his self-portrait, he fell down because his BP that time was 360 by 180. BP was high. People were debating whether Pickering and Platt, whether high BP to be treated or not to be treated. And that is criminal. Whereas another American president died because of tuberculosis in 1920 when the ATT was not available. Therefore, approach in my counseling, today we have in the armamentarium a cheap, a drug which is universally available. I call it 4A drug metformin. It is appropriate, it is available, it is affordable and accessible. Not to prescribe a drug, not in every patient where lifestyle is not possible or has not produced the result, or along with lifestyle is a criminal. So I approach from that point of view with maximum emphasis that it must be used. There are so many other ways like peer group teaching. There can be persuasion, family persuasion, group teaching. But I feel we must be very firm in our counseling. Thank you.
So your comments, Dr. Banshi Saboo, on this?
Sorry, what was the Surendra Gupta comment was?
No, basically the counseling part. I mean, the counseling, sir has clearly said the way he should go about, he will be going about in order to prevent progression of pre-diabetes to diabetes. Any thoughts on your way of introducing the counseling approaches in order to manage pre-diabetes?
So the counseling should be done rather not only for pre-diabetes, even the persons who is at the risk of developing diabetes. Primarily, we should try to prevent diabetes. So I do one counseling for all the patients who are relatives of the patients, the first cousin and the first relative of the patients, and even sometimes the wife and the spouse or the male partners, because they have the similar type of family history, the diet part and everything is common. Even they may not have the sugar at this point of time. They may not have dysglycemia or pre-diabetes. So the counseling is very, very important for them to understand the importance of monitoring the glucose level, whether they are in the level of pre-diabetes or not, for other metabolic problems for them, because they may also have obese, they may have dyslipidemia, they may have hypertension for that, and how they can be prevented, not only from diabetes, but also from other complication, which is mainly cardiovascular disease. So this counseling we should do for each and everyone. I mean, whoever you are coming to your clinic, Vijay, you and me can't go to the, publicly telling it that you are overweight and you should be counseled. But at least those who are coming to your clinic, you are seeing 30, 40, 50 patients in your clinic, and other 50 it's an opportunity for us to, intervene for other 30, 40 people, even without going to the society. And this can be a great social work, which we all can do easily in our clinic. And that is what I am doing for all my patients. They are supposed to sit with my nutritionist, dietitian, educator, and one of the education room, which we continuously do. And many of these, and this we don't charge for them. It's not like that. They should not feel that we are doing it for the purpose of taking the money. Sometimes their sugar is also checked and everything. So we don't do other camps, which is not required. Rather, you do in your clinic. And this is my advice to all primary care physicians and all the doctors. They can do in their clinic. This charity can be done very easily.
Bijay bhai, in addition to what Banshi bhai said, I said two things. That metformin it is 2-in-1 drug. It has got vasculogenic benefit. It has metabolic benefit. The multifarious benefits of metformin must be told to the people. Anti-aging, anti-cancer, anti-ill vascular effects, So I think metformin is a wonderful drug. And if it is taken for an indication like pre-diabetes, it will give maximal benefit. Sorry for the interruption. But I agree with Banshi bhai, what he said. A group teaching, family teaching is also important.
Thank you, sir. I think so. Banshi bhai has raised a very valiant point, and family as a unit should be considered. And probably we should try to propagate this whole stuff of screening as well as identification in the whole family and their supporting and their support staff as well. So
and tell them
proper support would work. Yes,
tell them the multifarious benefits of metformin, not only for the pre-diabetic conversion. It has a lot of bonus points. Correct.
So in that case, what are the other other pharmacological therapy which could be considered? I mean, barring metformin.
Can I take that question?
Yes, sir. That's for you, sir.
I think dapagliflozin is emerging as a drug for use for pre-diabetics. I'll tell you why. There are 4 points. Number one, it produces weight loss, 2 to 3 kgs to 5 to 7 kgs in certain population. Number two, it reduces the waste of the patient. It reduces the blood glucose, and it also gives benefit to the CRM, cardio protective, renoprotective, and metaboloprotective. So for all the 3 reasons, dapagliflozin is emerging as a drug for the pre-diabetes to diabetes. The other drug which was being used like acarbose, like Chairperson's experiment, is still there, but I don't think we are using any more acarbose as a converter, as a precursor, as a preventive drug from pre-diabetes. There are people who have used very low dose insulin. I don't belong to that group. People have also used a few other anti-diabetics to say that it can prevent, like with drug, like exenatide. It was not useful. It was a lot of side effects. So they said you can use it for preventing. You remember pre-diabetes going to diabetes because of the weight loss. So the main drug is metformin. Dapa may join. Acarbose has some evidence. Thank you.
Dr. Banshi,
Bijay, there is a lot of evidence which is now building up for the other GLP-1, as definitely GLP-1 is not getting tolerated by many of our patients or the persons with, but as it has been now approved and in obesity also, and in pre-diabetic conditions, there are a lot of clinical trials. It's not just for the prevention. It is like rather completely you are changing the pathophysiology of diabetes. Similarly, glitazone was also one of the molecule when in a prevention program, the rosiglitazone and the metformin and the lifestyle modification, all 3 were tried for that. So we are not using in clinical practice because of the problem of that it increases the weight. SGLT2, yes, it's a choice of the molecule. So in pre-diabetic patients, we can use this molecule to prevent them for diabetic, and at the same time to get them almost like in a normoglycemic condition when you can achieve the HbA1c of less than even 5.6 also.
Yeah, but Banshi bhai, there is a publication recently which has described all the drugs, liraglutide, semaglutide, in the entire GLP scenario, the gliflozins, etc. But the bottom line, it has said that the proof for the pre-diabetes diabetes prevention is today. The evidence will grow up in other substances is maximal in the metformin. And the most inexpensive and totally free of side effect drug is possibly metformin. But as you rightly said, one must know the other drugs that can be used. Thank you.
Any comments, Dr. Singh, Dr. N.K. Singh, sir?
Actually, this question I was planning to ask to Dr. Das, but I think, sir, Dr. Das has already given the answer. But when it is known that the pre-diabetes is leading us to many complications, metabolic complications,
Yes,
cardiac complications, could be the renal one and other things, then I think that definitely in future, although today it is not recommended by authorities, the DAPA or the SGLT2 inhibitors are going to play a great role in the prevention of diabetes also, because we already have many evidences that it can prevent. Even from the many trials, it has been shown. So I think this is a very, very important point today. But definitely, if you see the position of the metformin, it is still the Sartaj or the crown in the position. So I think we should stick to that at this point of time on the metformin. But already the counseling part has been beautifully discussed by Dr. Banshi and Dr. Das sir. I think before starting these drugs or pharmacological management, the role of the exercise and diet. That's very important. And I think in all conferences, we should devote some more time on the diet counseling part and the exercise. So this is what I would like to, Dr. Akash, what's your feeling, you can say?
NK, but now you can see that, last 10 years, almost
Yes,
in
sir.
every meeting, we have a symposium on nutrition. It was long back in RSSDI, thought of Dr. B.B. Tripathi, and on his name, there is a B.B. Tripathi symposia only on nutrition, and that's a theme symposia which we do in RSSDI also. But now across the country, whether it's a regional meeting, national meeting, anywhere, we have a meeting where we invite the nutritionists. Nutritionists are invited for a diabetes. And that is lifestyle modification is of utmost importance. And we started practicing. Those physicians can afford to have a nutritionist in their clinic. They can give them dedicated counseling by nutritionist. But if those who can't afford and they don't have the nutritionist in their clinic, at least they also understand the importance of nutrition counseling. And we ask all primary care physicians that whether the persons they are treating with a diabetes, pre-diabetes, or with any other metabolic problem, they should give a proper nutrition counseling and also give an exercise prescription. Just don't tell that 30 minutes chal jao, a walk, or any proper prescription of an exercise is also very much required for them.
I agree fully with Dr. Banshi, and what I feel is that the decrease in the age of counseling to 30 is the most vital step in pre-diabetes, because the earlier we detect these subset of population and the earlier we counsel them for lifestyle modification, that is the best thing to do basically. Rather than making them fearful of future diabetes, we should counsel them in a better way, that they do not feel that we are basically threatening them, but in a more friendly way, and we should sensitize them more towards lifestyle modifications, because almost the maximum benefit is with lifestyle modification. So that
and
is
plus early and aggressive control will also happen. If you get someone at 35 or 30, and rather than getting them at the age of 35, someone had developed diabetes and for 5 or 10 years, he has not been diagnosed, then probably he will diagnose with some or other complication. So if they are diagnosed at right time, we can aggressively control, and this early and aggressive control will give them lifelong a legacy effect, and they will have less and less complication also.
Dr. Patni, there was a question by Dr. Mahima, although it is out of context here, that whether if the GTI happens, the DAPA should be stopped or not. Can you take that question also here? Or can you answer that? There is no harm in answering that.
Definitely.
I think in our CME group, on WhatsApp group, this question has been answered hundreds of the times.
And
hundred of such clinical cases is been discussed.
Topic of controversy is always a topic of controversy, because some agree, some do not agree. But the fact remains that the SGL2 has made its own position in the armamentarium. So they should be utilized properly, and the counseling while prescribing SGLT is extremely important. That is where actually the lacking of proper counseling is the major deterrent for having an effective role as far as this particular molecule is concerned. So I'll request Dr. Akash Singh to take further questions, please.
There is a lot of talk about the cure of diabetes or reversal of diabetes by unauthorized people, especially the babas and a lot of other quacks, basically. So, how do we convince our patients not to fall for such scientific unproven traps, basically? This question is to Dr. Banshi Saboo, sir.
So, Akash, I fully agree. I will consider that this is not a problem of a individual doctor, rather advocacy from our physician group. As a organization, we should do it. And that is what we are trying, whether from RSSDA, Diabetes India, and different organization. We try to convince our patient, but at the same time, advocacy should be done at a larger, bigger platform, and maybe on a social media. They are more popular on the social media because anything which you are talk in their favor, someone can talk that we can cure your diabetes. People may be, this lucrative offer. They feel that this is something which they should accept or they should get this offer. But we know that it is more or less a cheating. Many of the times, rather, we give them a very scientific information. And that's the reason under RSSDI, we have started a social media platform and on a Facebook, and trying to talk on a general public on every time any expert is coming, and such myth we always try to talk on a social media, that people should understand that when they should call themselves the diabetes can have a remission. There is a clear-cut information and scientific information, how much weight loss is required for those who are becoming obese and overweight, how the diabetes can be done in the remission phase. It is, we call them a post-diabetes. We don't call it a completely cure for diabetes. My major problem is sometimes these babas and some of these quacks, they write even for a type 1 diabetes, a complete cure for them, or somebody who is severely insulin deficient, they put them diabetes is cured, and then they lead in a lot of complications. Recently, I have a patient, Dr. NK, who was having very high sugar, uncontrolled diabetes, a typical type 2 diabetic patient, had gone for 3 years and he stopped his all medication. And he was given different type of medication. And day before yesterday, when he came to my clinic with a creatine level of 3.2, and he started thinking that his sugar is getting controlled, but such a poor guy could not understand the importance of the diabetes can lead to complication. Now he had developed retinopathy also. He have a creatine which is high, 10 years of diabetes. Since last 3 years, no followed up, no medicines, no allopathic medication, and had gone. And these are the upper middle class people. I'm not talking of someone who is rural, uneducated. So I think it is our responsibility, combined responsibility. You and me are doing our level best in our clinic, those who are coming to our clinic. Somewhere in the public forum also we try. But as an organization, to do more advocacy, more and more advocacy is required. We have already started from our organization, but I am sure all of us, if anyone have any idea, this idea of advocacy, we should do it, and we all should combine for this advocacy on a different platform.
We were talking about glucose being the fifth vital sign, basically. So we, I think, should also advocate all the doctors who are practicing to have glucometer, so that all the patients who come in their OPD are at least checked for their blood sugars. So can you give your thoughts on this aspect?
So most of the physicians across the country, I don't think they don't have the glucose meter. When we were doing this 1 million test, the program, we had tried to give a lot of primary care physicians and even Rotary clubs and Lions Club also, when they had become partner, to give them a glucose meter. I started advocating to all my physician colleagues that, you can give gift to your surgeon and your gynecologist and your other non-physician category colleagues, as and when you are giving them gift, like on a Diwali time or on this time. So this can be a good gift for them for using for their patients. And that is what I do regularly for my other colleagues. This can be a good gift and that can be used for them in their hospital, in their OPD. And that's how, you can increase that glucose meter reading is very much required. Whenever a patient is coming to your clinic, please check the sugar, because 50% of them, they are diagnosed accidentally. And that's the only way how we can check their dysglycemia or glucose.
The last question from my side is, what is the role of sulfonylureas now, especially the low dose sulfonylureas for management of freshly erected diabetics?
So to be very frank, Akash, I am a strong supporter. It's like a judicious use of sulfonylurea is very important. So, sulfonylurea is blamed for hypoglycemia and weight gain, but because it is not been used in a very proper way, at that point of time, when the high dose of sulfonylurea was used, because the molecule were available only sulfonylurea, metformin, and insulin, UKPD's time. Now we have so many anti-hyperglycemic agent that you use them properly, and you find that when you need a good control of glucose, fast control of glucose, you want them giving them a glucotoxicity to go away early, then you use sulfonylurea maybe for short period of time. For long period of time, you may use short acting, smaller dose of sulfonylurea, and then, getting a good control of diabetes is very important. Some of the Western world, they advocate that starting insulin before sulfonylurea. I don't digest that point, and still most of the physicians in India would not like to put the patients on a 3 or 4 drugs, but they are not sulfonylurea. Suppose you have a patient who is on metformin, who is on acarbose, who may be on glitazone, who may be on gliptin, who may be on SGLT2 or even GLP-1. You had put all the patient or every patient on all 5-6 drugs, suppose, but still patient HbA1c is 7.5. Will you go straight way on insulin, or will you like to add the sulfonylurea? I mean, that is what we do in our clinical practice, that you modify the therapy in such a way. And after the using the continuous glucose monitoring, I can tell you that I'm using in many of my patients with sulfonylurea, but not getting any hypoglycemia, because judicious use of sulfonylurea at a right point of time, and then putting them on a very strict monitoring and a good monitoring device, which we have like CGM and all this thing, will not lead to hypoglycemia, no weight gain, and they will have very good control. So I still use and strongly advocate the use of sulfonylurea. And I agree with you with low dose sulfonylurea for our diabetic patients.
Dr. Akash, there is a question about the canagliflozin 300 for the obesity or the weight reduction.
So there is a data, Dr. NK, with the 300 milligram with the Motivist and Cana was there, and they had shown the data to support for decreasing the weight. Also, it was more effective in compared to the DAPA particularly, and with the EMPA also 300 milligram particularly. But with the cost is in a major consideration. You know that the 300 milligram, the cost is very high in compared to the DAPA off label, which is now very, very cheaper. So why to use for that particular benefit, the extra benefit of the weight or extra glycemic benefit? Rather, you can use always the other molecule to take care of that.
Yeah, Dr. Akash, any question more? Otherwise, you can conclude now.
We have no further questions.
I think we have came to the end, but I think the last message I would like from the Dr. Das and from the Dr. Saboo.
I think Dr. Das is now disconnected.
Yes, sir. So, sir, please give the message to all our physicians for this as far as this your 5th vital sign and the pre-diabetes is concerned.
So first and foremost, the message for all my clinician friends and physicians who are in India, they are more than 40,000. I mean, in one way or other way, they should join the CME group. That's number one message. That's very important. Because they get the regularly the clinical topic, which is very, very useful for their day-to-day clinical practice. So that's number one message which I would like to give. The second message for the vital sign as a sugar, I'm sure all physician colleague across the country, they started using glucose as a monitor, maybe as a 5th vital sign or not, but they should propagate this idea to their primary care physicians or the clinicians, as well as their non-physician clinic, who may be the gynecologist or surgeon, that as soon as patients come to their clinic, they should not miss an opportunity to check the sugar. So it should not happen that a person with years together for some or other thing going to other doctor and his sugar is never been checked. That should not happen. This is the second important message. For pre-diabetes, I can tell that in India, we have a large number of people who are in pre-diabetic condition. It's already the problem of 50% of the persons with diabetes are not diagnosed. So pre-diabetic population is still very large. So the point is counseling is done always for your patient and the relatives. The family should be counseled for complete metabolic profile, for diabetes, for pre-diabetes, for prevention of diabetes, for prevention of complication. And this we all can do in our clinic. This can be a great social service rather than going in society and doing other camps, and you are not able to. Rather, those patients who are coming to your clinic for any reasons, if you are practicing physician not as a diabetes, even they may be coming for other problems, screen them for metabolic problem, whether it's a blood pressure, lipids, sugar, everything. Screen them as well as educate them, counsel them, prevent their complication, and prevent diabetes also. With these two messages, once again, thank you, Dr. NK, for giving me an opportunity. Thank you, Dr. Bijay and Dr. Akash, very close friend of mine, for this wonderful opportunity, and particularly giving me platform with Dr. Ashok Kumar Das. And thanks USV team, Dr. Ashish, Dr. Anshali, and other people who had not only helped me for providing me the slides, but also for this wonderful opportunity. Thank you. Thank you very much.
Thank you very much, sir. I think before I conclude, I hand over again to the USB team, Dr. Ashish or Dr. Asil. I have a great pleasure that people like Dr. Banshi and Dr. Das today came, and they already saw this CME USB group initiative. And I am really very much thankful. I should not be thankful, but because they're part and parcel of this initiative, Dr. Akash and Dr. Patni. But anyway, thank you very much. And thank you, whole USB team. I am really in appreciation that for academic purpose, you have come forward and you have created this platform also and other things. And you have lots of plans in future too. So with this, with all the audience, with all our members, and I really am thankful. And I think you can conclude by further. That was it, yeah.
Yes, thank you. Thank you, Dr.
and good night.
NK Singh, sir. Yes,
thank you.
thank you. It's my privilege to propose the vote of thanks. I would like to start by thanking Dr. NK Singh, sir, for this great initiative. I would like to thank our chairpersons, Dr. Bijay Patni, sir, and Dr. Akash Singh, sir, for accepting our invitation and for enlightening us with all your words of wisdom. I would a special thanks to our speakers, Dr. A.K. Das, sir, and Dr. Banshi Saboo, sir, for sharing their expertise in all those pragmatic approaches with us. And last but not the least, thank you, Dr. Ashish, sir, my team, USV and tech team, for your immense support. Without this support, this program wouldn't have been possible. All may not be mentioned, but none are forgotten. Thank you so much, everybody, and have a great night ahead.
Thank you.
Thank
Good
you.
night.
Thank you.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
Thank you. Good night to all. Good night. Thank you.
Thank you. Thank
Thank
you.
you, sir.
Thank
Thank
you.
you so much.
Thank
Thank you.